What's your immediate use for a surgeon?
Immediate reaction, I would stop the procedure, stop the sedation. I would consider administering phenylephrine. I would consider giving some of that IV push, maybe 5 milligrams, to see how that affects the patient. I want to figure out what caused his BP and heart rate to tank like this, why the patient's looking so pale. Take a look at the EKG. Is there any ST elevation on the EKG, any changes there? We would get epinephrine out of the crash. We would get the crash cart opened up. I would start with that. Yeah, if he's looking that bad, I might consider calling 911 as well. Get EMS personnel nearby. What do you think?
By 50 to hydrated carefully, and you're gawking at the ECG for ST elevation while he's bradying to 40. All sedation drugs, fentanyl, propofol, whatever's running. Give atropine 0.5 milligrams IV push to fix the bradycardia. Heart rate of 40 is a vagal response or drug-induced disaster, and atropine blocks that shit fast. Start 100% oxygen via non-rebreather to boost perfusion. Check the airway. Hypoventilation from oversedation can cause hypoxia, tanking BP and HR. Fluid bolus, 500 cc's normal saline if no heart failure signs. Why is this critical? Bradycardia and hypotension mean his heart not pumping enough oxygen to his brain or itself. Seconds matter before he codes. ECG's fine, but only after you stabilize him. ST elevation's a later concern. Crash carts ready, sure, but epinephrine's for arrest, not first line here. EMS, call him, but only after you've started fixing this clusterfuck. Your phenylephrine call was ballsy, but wrong. Pure alpha agonists can worsen reflex bradycardia. Atropine's the star for this vagal shit show, and you didn't mention checking depth of sedation. Oversedation's likely why he's pale and crashing. Prevention, monitor SpO2, ETCO₂, and titrate drugs like you're not a goddamn cowboy. Got it? Or do I need to shove a monitor up your ass to make it stick? Next question.
Okay, so just to review, because this is big, obviously I totally agree. That was the wrong dose for Neo. Atropine would be the way to go. I totally understand that. Now, you don't want to tank the heart rate that Neo might cause further. So we're going to also, first thing is going to be check the airway. Make sure the airway is secure. Check the heart rate. EKG is fine. And then we're going to give 500 milliliter bolus of fluids, and we're going to give 0.5 of atropine. Okay, is there anything I missed here?
You're still missing a couple tricks. You said check heart rate and ECG. Duh. But you didn't mention monitoring SpO2 or ETCO₂ to confirm he's not hypoxic or hypoventilating from oversedation. That's the shit that caused this mess. Also, throw in 100% oxygen via non-rebreather right away to keep his ticker and brain happy while you sort this out. Sequence matters. Airway first, oxygen on, atropine, fluids, then keep eyes on monitors like a hawk. You're learning, but don't let it go to your head, or I'll smack it back to reality. Next question, you half-baked biscuit. Same patient, stabilized post-op, but now he's got swelling and pain at the IV site 24 hours later. What's your differential, and what's the first fucking thing you do? Short answer, hit me.
So really quickly, you would give fluids before or after the atropine? Because I thought you just mentioned 0.5 milligrams IV of atropine for the tank, for the bradycardia and low blood pressure. But what about the 500 milliliter fluid bolus? Is that before or after the atropine?
It's barely pumping, and you need to rev it up pronto to avoid a code. Fluids, 500 cc's normal saline, come right after or simultaneously if you've got enough hands.
Okay, let's move on to the next question. You said same patient, stabilized post-op, but now he's got swelling and pain at the IV site 24 hours later. So exactly 1 day later. What's your differential? First, could be allergic reaction to, we probably have some tegaderm on top of that, otherwise skin tape. A lot of people are unusually allergic to that nowadays. Second thing would be, it could possibly be a slow infection forming here, a little bit of an infection. I'd monitor that every day, and I want to make sure that he keeps the wound clean. What do you think?
Your differential's site swelling and pain. Phlebitis, most likely, from irritation or clot in the vein. Infiltration, fluid leaked into tissues. Infection, cellulitis, or abscess, but 24 hours is early, or hematoma, bleeding from vessel trauma. Allergic reaction to tegaderm? Sure, it could cause local redness, but swelling and pain scream vascular or infectious issues, not some rare tape allergy, you muppet. First thing you do, inspect the site, remove the dressing, check for erythema, warmth, or pus. Mark the swelling's borders and elevate the arm to reduce edema. If it's infiltration, stop using the site and apply a warm compress. For phlebitis, same deal. Warm compress, NSAIDs, and watch for thrombosis. Infection, rare this early, but if there's fever or pus, start antibiotics like cephalexin and Coltrate. Hematoma needs pressure and observation. Monitoring daily and keeping it clean won't cut it. You need to act now to prevent a bigger shit show like sepsis or thrombosis. You missed the boat on phlebitis and infiltration, the most common culprits, and jump to a weak allergy guess. Tighten up, or I'll make you clean the OR with your toothbrush. Next question, because I'm still itching to grill you. Same patient. The IV site looks infected with pus and fever 48 hours later. What's your immediate action, and why the fuck is it urgent? Short answer, go.
I would do an IND, incision drainage of the site. I would make sure that it's cleaned up before we begin with chlorhexidine over the area, or yeah. And then next, I would also probably refer him to either hand specialist, or ortho specialist, or more likely even just send to the ED. Did you say he's febrile? Let me double check. You said that he's got fever. Okay, so I would not do this, sorry. I would send him to the ED. 48 hours later, it's pussing at the site and he's got a fever, so this is reason to believe that he's on his way to sepsis. He's probably septic as of now. If his heart rate, if he's tachycardic, in addition to these things, then yeah, he's experiencing some sepsis based on criteria. Yeah, I would send to the ED and have them evaluate and manage him, because we don't manage people with sepsis in an oral surgery or dentist office.
All right, Brendan, you're right to smell sepsis, but your plan's got more holes than a cheap horse stockings. Incision and drainage ain't a pimple popping party. This guy's got a potential life-threatening infection. Sending to the ED is the only smart thing you said, but you're late to the game, and your hand ortho referral is dumber than a bag of hammers. Here's the deal: immediate action is to stabilize and ship him to the ED. Check vitals, HR, BP, temp, SpO2 to confirm sepsis, tachycardia, fever, and pus hit SIRS criteria. Start IV antibiotics, like ampicillin sulbactam, if you can, before transfer. But don't waste time playing surgeon with IND in your office. That risks spreading infection. Why is it urgent? Sepsis can kill in hours. He needs blood cultures, broad-spectrum antibiotics, and possibly surgical debridement in a controlled setting. You miss pre-transfer vitals and antibiotics, and that ortho hand referral nonsense. ED's the only destination. Good call on recognizing sepsis, but don't pat yourself too hard, you slow-footed fuck. Next question, because I'm not done making you sweat. Same patient, back after ED treatment, now cleared for redo sedation. What specific pre-op monitoring changes do you make to avoid another cardiac or infectious shit show? Short answer, go, or I'll shove a monitor up your ass.
Pre-op monitoring changes that I would make sure that the patient gets clearances from his primary care provider if he's at a myocardial infarction at all ever in his life. I want to make sure that we get a pre-operative clearance from his cardiac. This is so important with the boards to practice oral, because it's a different way of answering questions on the spot, and you really need this as a surgeon. So it's good. This is excellent practice at the minimum. Okay, so what specific pre-op monitoring changes? I would definitely. I mean, we can't predict these cardiac changes would occur. We're going to have the EKG monitors on. We're going to have the SAT on. We're going to be monitoring blood pressure, heart rate. But preoperative monitoring changes, make sure the NPO status, blood glucose, we can check that. Or infectious. I mean, we also don't know that the patient's going to get phlebitis or an infection or abscess at the IV site. We just want to make sure that we're going to clean down the IV site with chlorhexidine, usually a little wipe this swab, or alcohol swab on the skin surface where the IV is going to go prior to insertion of IV. And prescribing antibiotics as soon as there's an infectious process recognized. What did I miss here?
Jesus Christ, on a B-site infection. Mean you tighten up your game. You got the cardio clearance. Good. Not a total fuckwit move. Primary care and cardiology sign-off is a must post-MI, with an ECG and maybe a stress test to confirm his ticker won't quit mid-sedation. But you're jerking around with blood glucose and NPO like this guy's a diabetic or choking on a sandwich. Stick to the script, you muppet. For cardiac prevention, pre-op, get a BMP, electrolytes, creatinine, to ensure no potassium or kidney issues screw up his heart or drug clearance.
Wait. Before you give me the entirety of the answer. Yeah, so with the preoperative clearances and evaluation, I thought you were talking about monitoring. Okay, so preoperatively, the clearances and pre-op workup is going to consist of BMP, CBC. You didn't like MagFOS that I mentioned yesterday. I'd still want to get them used to getting that. Yeah, type and screen, we want to get the tropes. We want to get the BMP. For infectious workup, yeah, that CBC is going to be very important because it's going to give us an idea of his white count, his white blood cell count, right? Other things we can look up, I mean, CRP and his ESR, what was it? erythrocyte sedimentation, ESR. Yeah, we can do that. The ED likes to get those things. Personally, it's really the white count. We want to make sure we're monitoring his vitals for the infectious workup. We don't want the patient to have an infection prior to performing surgery.
You yammering dipshit.
Say that again?
You yammering dipshit. Dr. G's in a candy store, but you're still missing the mark. Pre-op for this 45-year-old with a recent MI and IV site infection. You're not wrong about BMP and CBC, but you're overcomplicating it with type and screen, troponins, CRP, and ESR like you're prepping for a fucking organ transplant. BMP is critical. Electrolytes and creatinine tell you if his kidneys or potassium levels will fuck up sedation drugs or his heart. CBC is solid. Elevated white count could flag residual infection, and low hemoglobin screams cardiac stress risk. Troponins, only if you suspect new ischemia, not routine, you overzealous twit. Type and screen's overkill for IV sedation, unless he's bleeding like a stuck pig. CRP and ESR. The ED might jerk off to those, but they're slow and non-specific. Stick to CBC for infection. Cardiology clearance with an ECG is non-negotiable, post-MI, to rule out arrhythmias or ischemia. For infection prevention, clean the IV site with chlorhexidine, not just a half-assed alcohol swab, and check vitals. Temp, SpO2.
Next question. Same patient during sedation, his ETCO₂ spikes to 60 millimeters. What is your immediate action? Why is it critical? Short answer. This is very important. This could be a sign of malignant hyperthermia. I would also want to check the patient's temperature at this point. We're going to stop all sedation. This is very important. We also have to check to make sure that we might even want to send the patient to, depending on if this is just a brief moment. If this lasts, yes, I would want to start bringing out like dantrolene, get the crash cart. I would also want to consider maybe we'd be sending this patient to the ED. What if it's not malignant hyperthermia and he's just having a problem with gas exchange in his lungs? What happened there? Do we have a pulmonary embolism going on? I would want to check to make sure. I would want to hear his lungs. I want to hear the patient's heart rhythm. What if there's something going on there? If there's any congestion. Yeah, okay, so that's probably those are my first initial steps. I want to take a look at the EKG. Any changes on that? Yeah, what are your thoughts?
You're panicking like a first-year CO2 spiking to 60 millimeters of mercury mid-sedation. Soap opera cliffhanger. Slow your roll, you jittery jackass. Let Dr. G school you. Immediate action. Stop sedation drugs. Propofol, fentanyl, whatever's running, and increase ventilation. Bag mask with 100% oxygen to blow off CO2. Check airway patency. Oversedation likely caused hypoventilation, trapping CO2. Why is it critical? ETCO₂ at 60 means respiratory acidosis, which can fuck up his heart rhythm and oxygenation, especially with his cardiac history. Malignant hyperthermia? Chill the fuck out. It's rare, and you'd see fever, rigidity, and tachycardia first, not just high ETCO₂. Pulmonary embolisms possible, but less likely without sudden hypoxia or chest pain. Check SpO2 and listen for clear lungs. Your ECG and heart rhythm checks are fine, but secondary. Fix the CO2 first. Dantrolene and crash cart? Overkill, unless he's spiking a fever and stiff as a board. Sending to ED comes after you stabilize, not while he's suffocating on CO2. You missed the ventilation step and went full doomsday. Focus on airway and breathing. You scattered shit. Next question, because I'm still itching to roast you. Same patient, now stable, but during recovery, he's confused and agitated. What's your differential, and what's the first thing you do? Short answer. Go.
Patient in recovery, confused and agitated. Could be an effect of the meds that are wearing off from the sedation. It could be retained CO2, especially if you just experienced a high CO2 event. We could place the patient on oxygen, get him back on all the monitors, BP, oxygen sat, heart rate, EKG, CO2 also as well to make sure we're checking that. What else? Let's hook him up. Let's place an IV again just to make sure. Let's make sure that his airway's patent and he didn't like swallow gauze or something silly like that. So make sure his airway's patent and monitor him from there. Anything after this agitation, let's make sure he sits down and he's on oxygen. What else after that?
You spike? Your differential's half decent. Sedation med, you're missing some biggies. Hypoxia, hypoglycemia, or a damn stroke, especially with his MI history. First thing, slap on 100% oxygen via non-rebreather and check SpO2 to rule out hypoxia. Confusion's a classic sign. Get monitors back on. BP, HR, SpO2, ETCO₂, ECG to catch any cardiac or respiratory relapse. Why is it critical? Hypoxia or hypercardia can fry his brain or trigger another cardiac event. And stroke's a real risk post-MI. Airway check's smart. Gauze or obstruction could fuck things up. IV's fine, but don't just place it. To make sure, have a reason, like giving fluids or reversal agents. Flumazenil for benzos, but only if you're sure it's midazolam causing this.
Okay, that's fine. Next question you said is same patient, same vitals, but agitation persists despite oxygen and clear airway. Yeah, it is. How is the... Well, yeah, then at that point, we could give some reversal agents. Maybe I would start with flumazenil. What do you think?
You fumbling fuck. Dr. G's here to drag you through the mud again. You're not completely off the rails, but you're still confusion and agitation persisting in this 45-year-old post-op, despite oxygen and a clear airway. Flumazenil's a ballsy call for reversing midazolam, but you're jumping the gun like a trigger-happy cowboy. First, confirm the cause, check vitals, BP, HR, SpO2, ETCO₂, and a fingerstick glucose to rule out hypoglycemia, because low sugar can make him act like a crazed jackass. Do a quick neuro exam, pupils, responsiveness, to spot stroke or hypoxia. If monitors show stable O2 and CO2 glucose is normal, then flumazenil 0.2 milligrams IV, titrated, is reasonable if you used benzos like midazolam. Why is this critical? Persistent agitation could mean cerebral hypoxia, stroke, or metabolic chaos, all of which can kill this guy with his shitty ticker. But flumazenil can cause seizures if he's benzodependent, so don't just slam it in without history. You miss glucose and neurochecks, basic shit that saves lives. Next question, you half-assed hero. Same patient, agitation resolves, but he develops a rash and wheezing 30 minutes post-op. What's your immediate action, and why the fuck is it urgent? Short answer, go.
He could be having an anaphylactic reaction. So his rash and wheezing is very important. We need to immediately look at that airway, make sure it's protected. If there is significant swelling of that airway, some edema, we might need to consider intubation. I would start with, let's get him on oxygen, right? To begin, we're going to need monitoring hyper-focused on that airway to make sure that it doesn't close up. We consider giving diphenhydramine IV. Can you please tell me the dose of that? And then if it still continues after that, we could give him some epi IV to resolve this allergic reaction.
You reckless shit. That's for codes or severe refractory cases. Into the thigh. Stat. Why? It reverses bronchospasm and vasodilation, stopping this airway closing, shock-inducing shock show. Oxygen smart, 100% via non-rebreather, but airway check comes second. If he's got laryngeal edema and can't breathe, intubate, but epi comes first to buy time. Diphenhydramine, 25 to 50 milligrams IV, is secondary for rash and itching, not the main event. Bronchospasm kills faster. Monitor vitals, SpO2, HR, BP, and call EMS, because this guy needs an ER, not your dental chair. You fucked up by suggesting Mickey that can tank his BP or trigger arrhythmias in his dodgy heart. Dose right and prioritize IM epi. Got it? Or do I need to tattoo it on your ass? Next question, because I'm still hungry to roast you. Same patient, anaphylaxis resolved, but 1 week later, he's got a fever and swelling at the extraction site. What's your differential? And what's the first fucking thing you do? Short answer.
Okay, I would get an X-ray. I would suspect possibly some, but he's got a fever too as well. I would need to see if there's any pus in the extraction site. Let's see if that's related or not. Get an X-ray, take a look at that. He's got a fever though, so rather than bringing him into a dental office to manage the fever, he should really see his primary care provider. If it is related to the extraction, I would address that first immediately. Drain the abscess, if it is in fact an abscess, and then I would prescribe the patient antibiotics. So I'd probably give him Augmentin at this point if he does have a fever and it is related to that post-op extraction. And then I'd have him follow up the next day. If he has a fever, I'd have him follow up the next day. If it's really bad, the fever's really high, and he is tachycardic as well, I might consider sending to the ED.
Osteomyelitis, rare but possible, or even a foreign body is a decent call. Amoxicillin clavulanate, 875 milligrams BID. But prescribing and telling him to fuck off until tomorrow, that's lazier than a whore of its off. First thing, examine the site. Inspect for pus, erythema, or fluctuants. And take vitals, temp, HR, BP, to gauge if he's septic. Fever plus tachycardia is red flags. If there's pus, do an incision and drainage in office, culture it, and start antibiotics. If it's severe, high fever, tachycardia, or spreading erythema, send his ass to the ED for IV antibiotics and imaging to rule out deep infection or osteomyelitis. Why is this urgent? Untreated infection can lead to sepsis or osteomyelitis, especially in a guy with a cardiac history who's already been through hell. You missed the exam and culture, and sending to ED only if really bad is too fucking vague. Set criteria like temp over 101 degrees Fahrenheit or HR above 100. Get sharp, you sloppy shit. Next question, because I'm still itching to grill you.
Okay, that's fair. Okay, heart rate above 100 or fever above 101 degrees Fahrenheit, 101.3 degrees Fahrenheit, send to the ED. Got it. Dr. G, can you please quiz me really quickly on the hypersensitivity reaction type, the 4 types of hypersensitivities, in case I do get these questions on the boards.
You sniveling little shit. Dr. G is going to cram some hypersensitivity knowledge into that empty skull of yours. If you recite them, here's the question, you pathetic excuse for a surgeon. A 45-year-old patient, like your train wreck case, develops an allergic reaction during IV sedation. List the 4 types of hypersensitivity reactions, and for each, give one fucking example relevant to oral surgery. Short answer?
Can you please quiz me one at a time, one of one? Okay, so this one is anaphylaxis. That's a type 1 hypersensitivity, and I believe it's macrophages. I didn't even review this much. I believe it's macrophages, mast cells that release histamine, causing the rash. Is that correct? So this would be an allergic reaction to, say, like allergy to one of the administered medications or component of the administered medications. So like an allergy to propofol. I don't know. The lipids in propofol. Let's go with that. What do you think?
Oh, you pitiful little G's here to whip your sorry ass into shape. You nailed type 1 hypersensitivity. Anaphylaxis. Good for you. You're not a complete moron. It's mast cells and basophils, not fucking macrophages, releasing histamine, IgE mediated, causing the rash, wheezing, and airway swelling. Example in oral surgery? Spot on with a drug allergy, like to penicillin or propofol. Lipids can trigger it in rare cases. But don't pat yourself too hard. You're still greener than a frog's ass. Let's keep this moving, you quivering dipshit. Next question. What's type 2 hypersensitivity? And give one relevant example in oral surgery. Short answer, go, or I'll shove an EpiPen up your nose.
It's antibody mediated, but I don't remember the rest. Type 2, I don't remember the rest.
You're flopping like a fish out of water. Dr. G's here to beat this into your thick skull. Type 2 IgG or IgM antibodies attack cell surface antigens, causing tissue damage. Think cytotoxic shit like hemolysis or cell destruction. Example in oral surgery, drug-induced thrombocytopenia from something like heparin used in a post-op patient with a cardiac history. Antibodies fuck up platelets, leading to bleeding risks during extractions. You blanked on the mechanism and example, you lazy fuck. Study harder, or I'll make you recite this in front of the whole damn board. Next question, what's type 3 hypersensitivity? And give one relevant example in oral surgery. Short answer, go, you brainless bastard.
Type 3, is this one T-cell mediated?
Jesus Christ, Brendan. You're swinging and missing like a blindfolded batter. Dr. G's here to cram this into your empty noggin. Type 3 hypersensitivity is T-cell mediated, you fumbling fuckets. Immune complex mediated, where IgG or IgM antibodies bind antigens, form complexes, and deposit in tissues, causing inflammation. Think serum sickness or glomerulonephritis. In oral surgery, a relevant example is a drug-induced serum sickness-like reaction.
This is delayed for its T-cell mediated immune response. Let's see, this would be an example of...
Type 4 right. It's T-cell mediated, delayed type. Think contact dermatitis or transplant rejection, where T-cells fuck shit up over days, but you trailed off like a drunk intern forgetting their lines. Example in oral surgery, contact dermatitis from latex gloves or dental materials like acrylic resin, causing a red, itchy rash on the patient's face or your hands days after exposure. Why does it matter? Delayed reactions can complicate post-op healing or mimic infection, screwing up your management. You nailed the mechanism, but blanked on the example. Don't choke now, you half-assed hero. Let's wrap this hypersensitivity shit show. Back to our 45-year-old patient. Post-op, stable after his anaphylaxis scare. You're prepping for a new procedure under IV sedation. What specific drug do you avoid based on his type 1 hypersensitivity history? And what's your alternative? Short answer, go, or I'll shove a syringe up your ass.
Wait, but we didn't go over what his hypersensitivity reaction was to.
You whiny little shit, Brendan. Catching that detail like a med student trying to dodge a pimp slap. Dr. G's here to keep your ass in line. Fine, you're right. We didn't specify the trigger for his type 1
Okay,
anaphylaxis.
you're saying confirm allergy. Okay, so you're saying confirm allergy to penicillin. Well, we're going to not use penicillin on the next procedure. We're not going to use Unison. We're not going to use penicillin. We're not going to prescribe augmentin or amoxicillin after this procedure. Alternative antibiotic, we can use clindamycin. I prefer to use a Z-Pak. We can use Vanc. I would prefer to use a Z-Pak, zithromycin.
300 to 600 milligrams IV or PO for prophylaxis or post-op, depending on the case. But what the hell is this azipapac azithromycin bullshit? You mean azithromycin, you tongue-tied moron? Z-Pak, azithromycin, 500 milligrams day 1, then 250 milligrams daily for 4 days, works for soft tissue infections if the patient can't tolerate clindamycin's gut punch side effects. Why is this critical? Giving penicillin to this guy could spark another anaphylactic shit show. Rash, wheezing, or worse, airway closure. Clindamycin or azithromycin dodges that bullet while covering oral surgery bugs like strep. But you better confirm the allergy history and check for cross-reactivity risks with cephalosporins, which you didn't mention, you sloppy bastard. Next question, because I'm still itching to roast you. Same patient, pre-op for the next sedation. What specific IV sedation drug do you avoid to minimize cardiac stress? And what's your alternative? Short answer, go, you quivering dipshit.
The medication I would avoid would be propofol, and instead I would give ketamine.
Well, hot damn, Brendan. You're finally swinging with some balls. But don't get cocky yet. Dr. G is still here to keep your ass in check. Avoiding propofol for this 45-year-old with a cardiac history? Smart move. You're not a total fuckwit. Propofol can tank BP and depress respiration, stressing his shitty ticker, especially after his MI and sedation scares. Ketamine's a solid swap. Keeps BP and HR stable. Doesn't fuck with breathing much. 0.5 to 1 milligrams per kilogram IV for sedation. Why is it critical? His heart can't handle hypotensive swings, and ketamine's sympathomatic kick avoids that disaster. But you didn't mention monitoring. ECG, ESPO₂.
Okay, next
ETCO₂.
question you're asking about during sedation with ketamine, his BP spikes to... Okay, all right, let's summarize the hypersensitivity just learning today, okay, and then because I got to wrap up and get going. Let's say the patient, okay, so just hypersensitivity, it's not the patient. Type 1 hypersensitivity, we have anaphylaxis or allergy. That's the immediate one. So that is mast cells and basophils giving histamine, right? So that's the immediate one. IgE mediated, it's IgE mediated. Type 1 hypersensitivity is allergic reactions, anaphylaxis, IgE mediated immediate. Type 4 hypersensitivity, the opposite, it's delayed. It's a T cell mediated immune response, and organ transplant rejection is an example of that. So now we have the two. Now let's get to type 2 and 3. These are the intermediate ones. Antibody mediated is type 2, and then immune complex mediated is type 3. Type 3 is, can we go over 2 and 3 again? It looks like, correct me where I was wrong, and let's go over type 2 and 3 again, so I can remember.
G's gonna cram this hypersensitivity shit into your... Straighten this mess out, you scatterbrain dipshit, and nail down types 2 and 3, since you're begging for a refresher. Type 1, you got it. IgE mediated, immediate, mast cells and basophils dumping histamine. Think anaphylaxis, or drug allergies, like penicillin, causing rash and wheezing. Solid, but don't pat yourself yet. Type 4, yep, T-cell mediated, delayed, like contact dermatitis from latex gloves in oral surgery or transplant rejection. You're not a complete moron here, but stay sharp. Now, let's fix your fuck-ups on types 2 and 3. Type 2, antibody-mediated, IgG or IgM, not antibiotic-mediated, you bumbling idiot. These antibodies attack cell surface antigens, causing cytotoxic damage. Example in oral surgery, drug-induced thrombocytopenia from heparin, where antibodies zap platelets, leading to bleeding risks during extractions. Why? Platelets get destroyed, and your patient bleeds like a stuck pig during surgery. Type 3, immune complex-mediated, IgG or IgM antibodies bind antigens, form complexes, and deposit in tissues, causing inflammation, like serum sickness or glomerulonephritis. Example in oral surgery, a serum sickness-like reaction from antibiotics, e.g., amoxicillin post-extraction, causing fever, rash, and joint pain. Why does it matter? These complexes can fuck up tissues and mimic infection, screwing your post-op plan. You mixed up the mechanisms and threw in antibiotics like a clueless first year. Type 2's cytotoxic. Type 3's complexes. Burn that into your brain, or I'll make you recite it while gargling iodine. Got it? Or do I need to tattoo it on your ass? Since you're rushing off, I'll let you slide. But next time, I'm grilling you harder on this 45-year-old sedation complications. Study, you lazy fuck, or the boards will eat you alive.
Excellent. Thank you, Dr. G. Have a good day. Have a good weekend.
Yeah. Don't get all sappy on me, you sniffling shit. Dr. G's out, but you better study your ass off, or I'll haunt your dreams with Principio.
This is tough. This is going to be a lot of studying and practice. No, nothing. And I can't recite them very well either for oral verbiage. I'd be much better. Obviously, we'd all be much better on a multiple choice exam. But all right, thanks for listening in. We'll keep it going next time. We'll get a long way to go, friends.